Assalamualaikum and very good morning, everyone. Thank you for coming to our CMB for the Health today. So my name is Prof. Mukri from the Department of Obstetrics and Gynecology. And today I'm going to chair the first session of our CMB breakfast at UM Health. It will be delivered by one of our staff in the department, which is Dr. Nadia Abdullah, who will be giving us an update and information on how to enhance the maternal immunization for the improvement of maternal and neonatal health. Dr. Nadia has been with us for the past 2 years in the department, and she is currently the clinical specialist of the department and has a special interest to go for a fetal-maternal medicine soon. And hopefully that we can enlighten with her talk today about the topic. So over to you, Nadia.
Thank you very much, Pramukri. Thank you, everyone. Assalamualaikum and a very good morning to everybody who joined us today. So my name is Dr. Nadia binti Abdullah. So as the introduction, I'll be giving a talk on enhancing maternal immunization for the benefit of maternal and also neonatal health. Okay, I'll share my screen. In this talk, I will start a bit of introduction on maternal immunization and then principles underpinning maternal immunization and current recommendation of vaccination in pregnancy, which I will talk more on influenza vaccine, Tdap vaccine. Then I'll go on ongoing challenges in maternal immunization. And lastly, I will talk a bit about new kids on the block, which is the newly approved vaccine and also vaccines in development. So for the introduction, maternal vaccination has enormous potential to protect not only mothers from vaccine-preventable diseases, but also their infants through the passive acquisition of protective antibodies before they themselves are able to acquire protection through childhood immunization. Vaccination during pregnancy is warranted when the risk of exposure is high, the infection risk poses to the mother is quite high, and also vaccine is unlikely to cause any harm. Understanding the mechanism by which antibodies are transferred across the placenta is important to develop optimal maternal and infant immunization strategies and make decisions about the timing of vaccination in pregnancy. One of the greatest success stories of maternal immunization has to be the effective elimination of maternal and neonatal tetanus through maternal vaccination throughout the world. And also another story that I can think of is about COVID vaccination in pregnancy also, which we can see the marked reduction in severe COVID-19 infection in pregnancy. Okay, so vaccines that are recommended in pregnancy currently are influenza vaccine and Tdap vaccine, which is the tetanus, diphtheria, and pertussis vaccine. And furthermore, we also have additional vaccines in special circumstances and also in pregnant women in special conditions, such as anti-hepatitis A and B vaccine, pneumococcus and meningococcus vaccine, and also Japanese encephalitis vaccine. On the other hand, we also have to remember that there are several vaccines that are contraindicated in pregnancy and should be avoided, which come from the live attenuated and also inactivated vaccine, such as the rubella, measles, mumps, and varicella vaccine, BCG vaccine, oral poliovirus vaccine, and HPV vaccine. However, if a live vaccine is inevitably given to a pregnant patient or the patient becomes pregnant within 4 weeks after the administration, they should be counseled about potential side effects. However, so far, no harmful adverse side effects have been documented, but there were a few cases of subclinical infection. Therefore, termination of pregnancy in these cases is not warranted. Okay, principles underpinning maternal immunization. Maternal immunization provides transient immunity to the newborn by the transplacental transfer of maternal immunoglobulin G, IgG antibodies. However, after delivery, in postpartum, during breastfeeding, maternal IgA is secreted in the colostrum and breast milk, which will seed the luminal tract of the newborn, conferring defense at the mucosal level against pathogen of the gastrointestinal and also respiratory tract. Then we have to know that healthy pregnant patient can also mount a similar immune response to vaccine as healthy non-pregnant patient. So it's equally effective in pregnancy or without outside of the pregnancy. Factors affecting IgG transfer from the mother to the fetal circulations. We have a few factors. Amount of FcRn expressed by the syncytial trophoblast and total maternal IgG levels, which is the concentration of the antibody in the maternal serum. Gestational age, which will start during the first trimester of pregnancy and increase exponentially over time. Most of the IgG transfer occurs after 28 weeks of gestation. Another one is IgG subtype affinity for the FcRn receptor, whereby IgG1 is the subtype of antibodies transferred most efficiently to the fetus, followed by IgG4, IgG3, and IgG2. And IgG1 and smaller amount of IgG3 and IgG4 are induced predominantly by vaccine containing protein antigen, such as the Tdap vaccine. Okay, when we are considering about maternal immunization, there is a controversial theory or effects of immunology blunting, where the presence of maternal antibodies is thought to decrease antibody production by the infant after they got their own vaccination after they are born, consequently a decreased protection for the child. This phenomenon has been observed in a few studies where children born to immunized mothers had lower antibodies level than children of non-vaccinated mothers. However, specific antibodies reached the seroprotective levels for all antigens. Therefore, they concluded that this immunology blunting does not appear to reduce the vaccine effectiveness. Okay, we go now to current recommendation of vaccination in pregnancy. The first, I will talk about influenza vaccine. So influenza vaccine is recommended during pregnancy to protect pregnant women and their newborns from severe influenza infection. So just like a COVID-19 vaccination last time. Okay. So in studies, they found that pregnant women were 7 times more likely to be hospitalized when compared with the non-pregnant population. And these infected women, they also observe that adverse pregnancy outcomes, including preterm birth and also fetal death. Okay, and infection in newborns aged less than 6 months is associated with a severe disease and ICU admission. Okay, and currently, no influenza vaccine licensed for the use in infants less than 6 months old. Hence, maternal influenza vaccination is the only strategy currently available to prevent influenza in these very young infants. Okay. So for influenza vaccines, we have 2 types. One is inactivated vaccine. Another one is the live attenuated influenza vaccine. So the one that is safe in pregnancy is the inactivated vaccine. So pregnant women are not at higher risk for adverse events following influenza vaccination than non-pregnant adults. So you can counsel the patient that even though you're pregnant, so the risk of you getting a severe adverse effect is similar as the non-pregnant population. Influenza vaccination can also be safely administered at any gestation, including the first trimester, with multiple systematic reviews showing no association between influenza vaccination during pregnancy and also adverse birth outcomes. So basically, influenza vaccination we are giving to cover both maternal and also infant. So because we want to protect the mother from severe infection, so it can be given even earlier in the first trimester. Next, we go to Tdap vaccine, which is the tetanus, diphtheria, and also pertussis vaccine. Okay, because of the antitoxoid vaccination before this, so we can see that the tetanus is very uncommon. Okay, even diphtheria also are very uncommon nowadays, but then pertussis is still globally endemic. Infants in the first month of life are at higher risk of severe complications of pertussis infection, including pneumonia, apnea, encephalopathy, and multi-organ failure. In Malaysia, up to 19 of August 2023 this year, Ministry of Health reported about 329 cases of pertussis with 23 deaths. And 57.4% of positive cases are children under 12 months old. Okay. At least 3 doses of pertussis containing vaccines are required for infants to achieve a protective level of antibodies. Therefore, infants less than 6 months old remain vulnerable. Okay, if you can see here, this is the Malaysian, our national immunization program. So, see on the fourth row, which is the vaccine of diphtheria, tetanus, and pertussis. It can only be given starting from 2 months old, and the next dose is 3 months and also 5 months old, and they will get a booster at 18 months. So if you can see from birth until 1 month old, there is no coverage or whatsoever for pertussis infection. Therefore, maternal immunization is the only way to provide these children, these small children, with the antibody against pertussis. The WHO has recommended providing 1 dose of Tdap to all pregnant women at each pregnancy, regardless of previous vaccine history. And based on their recommendation, Tdap should be administered at 27 to 36 weeks of gestation, although they said that it could be given at any time during pregnancy because of the safety profile. Okay. And it takes at least 2 weeks post-vaccination for maternal pertussis antibodies to take, and also some also put about 4 weeks to reach its maximum antibody levels. And vaccine effectiveness in preventing pertussis infection drops to about 38% if given 0 to 6 days before birth. Okay. Because this pertussis vaccine, the antibodies will wane over time, over a few months. That's why they recommend that each pregnant woman should have this Tdap vaccine at each pregnancy, regardless of the spacing. Okay, even though they got pregnant in the next year, within 12 months, they still have to get another Tdap vaccine during the subsequent pregnancy. There are some variation in recommendation in Tdap vaccine. So in the United States and Great Britain, they recommend of vaccination between 26 to 36 weeks gestation following WHO recommendation. In Switzerland, on the other hand, vaccine is recommended to be given as early as second trimester, around 13 to 26 weeks of gestation. Based on a study by Eberhard et al. That showed immunization during the second trimester, which is around 13 to 26 weeks of gestation, elicited higher antibody titers in newborn compared with later vaccination at the trimester, which is around 27 to 36 weeks of gestation, a finding that was also observed with preterm birth. Okay, so that's why if we follow the Switzerland one, this recommendation may be considered in pregnancy, which we think that it is at increased risk of preterm delivery, or it has a pertussis outbreak in that area, to allow for a longer placenta exposure to higher antibody levels and maximization of antibody transfer. Okay, so if we see a patient in a clinic, so when we are counseling the patient for Tdap vaccine, when they ask when is the appropriate time, so we have to see all the history, the antenatal history and obstetric history, whether they are at risk of preterm delivery. So maybe for that patient, instead of giving at 30 weeks and above, we have to give a bit earlier. Okay. Infants of mothers vaccinated during pregnancy have been shown to be 91% less likely to acquire a pertussis infection in the first 3 months of life compared with infants whose mother were not vaccinated. In a retrospective study of nearly 150,000 infants exposed in utero to Tdap vaccine were better protected against pertussis during the first year of life than unexposed infant at every level of DTaP vaccine exposure. And so this protection is higher than previously reported for postnatal maternal vaccination, which we call a cocooning strategy, whereby we administer vaccine to all the members of the household in order to prevent them from getting pertussis infection and subsequently infect the newborn. And just like influenza vaccine, it is proven safe, and which there is no association between Tdap vaccine and adverse events such as preterm delivery and also low birth weight. Okay, despite proven benefits and recommendation by the WHO and several other bodies, the vaccine uptake, especially in Malaysia also, is still quite low. Okay, so there are ongoing challenges on why the vaccine uptake is still very low. Number one, we can one of the factors could be the pregnant women's understanding of the importance and also the safety. Just like the COVID-19 vaccine last time, most people are very concerned about the safety and also the safety of the vaccine towards pregnancy. They are concerned whether this vaccine can cause any harm to their babies and to their self as well. Okay, so we have to educate the patient, the pregnant women, about the importance and also the safety about of the vaccine, so that can increase their understanding and also their uptake and willingness to get the vaccination. That's why we as the obstetrician, especially, and also the healthcare provider, have to equip ourselves with the current recommendation and also knowledge, so that we can counsel the patient on the benefit and also the importance of getting vaccination during pregnancy for their benefits and also for the newborn. Okay, because healthcare provider recommendation has consistently been shown to be the key determinant in encouraging women to receive vaccine. Even though they have doubts, then after we are our counseling, usually they are quite comfortable, they're quite certain that this vaccine are safe, so they are willing to get the vaccination. Okay. However, even though we already tackled the lack of understanding, we already given a good counseling to the patient. If money and financial constraint is a factor, it's still we still can't do much. Okay, that's why integrating maternal vaccination into routine antenatal care can improve pregnant women's access to vaccines and thereby improve vaccine coverage. Okay, because now for influenza vaccine and also Tdap vaccine is not part of the free vaccine provided in pregnancy. We only have anti-tetanus toxoid that is given free, but then for Tdap and also influenza vaccine, the patient have to pay currently. Okay, there is a press release by Ministry of Health on the 28th of August this year, where there's going to be an implementation of the provision of Tdap vaccine to expectant mothers nationwide, starting from next year, 2024. And based from our Menteri Kesihatan, Dr. Zaliha Mustafa, that time, once implemented, all pregnant women, including non-citizens, will be given one dose of Tdap vaccine in their second to third trimester between 13 to 36 weeks. Okay, and this vaccine will be given free at all Ministry of Health primary care facilities, which is the Klinik Kesihatan, starting next year after they able to get all the procure all the necessary and the adequate amount of vaccines to cater for about 500,000 of pregnant ladies each year. Okay, so based on this press release, they said that this initiative will involve a yearly allocation about 25 million ringgit per year. Okay, so let's hope that the process of getting this Tdap vaccine is smooth, and so this initiative can be started early next year. Okay, about at the end of my talk already, so I will talk a bit about new vaccines. So this is just a new vaccine that has been approved by US FDA recently in August 2023. So it's a respiratory syncytial virus RSV vaccine. Why is this vaccine is important? Because RSV causes significant morbidity and mortality in infants, with the greatest burden of disease in low and middle income countries. So this maternal RSV vaccine has been approved by the US FDA in August 2023, and it has since been endorsed by the CDC. So it's only so far, I think in Malaysia we don't have this. Only in US that they started to counsel patients to get this vaccine. Okay, so this vaccine, based on studies, are safe during pregnancy and reduces the risk of severe RSV bronchiolitis in infants if maternal administration occurs at least 14 days before birth. Okay, so this vaccine also they recommend to be given around 27 to 36 weeks. And GBS vaccine, group B streptococcus vaccine, is this vaccine is still in development, not yet being endorsed by anybody. Why this vaccine is important? Because GBS is quite common in women, okay, and incidence of early and late onset GBS disease in infants is quite high. And current preventive strategies, just antenatal, screening, and intrapartum antibiotics prophylaxis for those mothers still positive. Okay. Trivalent GBS polysaccharide protein conjugate vaccines have been administered to pregnant women as part of phase 2 clinical trials. And from this trial, they have been shown that to be immunogenic, safe, and well tolerated. And phase 1 and 2 clinical trials of hexavalent GBS vaccine is currently underway. So this vaccine is still not yet available, still have to go through phase 3 before it can be endorsed to be used. And the next vaccine that is still underway, in development, is cytomegalovirus or CMV vaccine. This vaccine is important because CMV is a common congenital viral infection and can lead to significant infant morbidity such as deafness and also other CNS manifestation. And development of maternal CMV vaccination to reduce the incidence of congenital CMV has been ongoing, and phase 2 and 3 studies are still underway. Okay, it's the end of my talk. So as a conclusion, maternal influenza and pertussis vaccination in pregnancy are two safe interventions that should be part of routine antenatal care for all pregnant women. However, achieving a high vaccine coverage remains an important challenge. Therefore, efforts need to be directed towards improving maternal knowledge and addressing maternal concern about vaccine safety, facilitating healthcare provider recommendation of vaccine, and ensuring access to maternal vaccines at the point of antenatal care. Thank you.
Thank you very much, Dr. Nadia, for the updates on the current and the future vaccination that we can actually offer to the pregnant women. So we still have around 5 minutes for the question and answer session. So for those who want to ask question, you can actually type it in the Q&A chat box there down at your screen. And I will try to read the question and ask Dr. Nadia with regards to your queries. So since there's no question now, Nadia, how about the COVID-19 vaccination that has been rolled out before, and there's some, resistance for the mother. How about that? Because it's what kind of vaccination it is, and is it safe in pregnancy? Just to tell the audience.
So I think last time we had this CMA ready by our colleague Dr. Raymond. So there are a few types of COVID-19 vaccine, and it's all come from non-live or non-live activated vaccine. So it's proven safe, and also we can see from previous incidents also that the COVID-19 infection in pregnancy, the numbers of severe cases drops after we introduce the vaccination of COVID-19 in pregnancy. After that, okay, so before that, we can see all the hoo-ha that Siti Sarah also died because of COVID-19 infection because she wasn't immunized and everything. So after that, so the uptake of COVID-19 vaccine after the incidents, I think in pregnant patient, they increase. And for now, I think the numbers are quite low. And most of the patients that we saw in the clinic all completed the COVID-19 vaccine, even with the booster, even with the booster as well. So the uptake is quite good already. And now we rarely see COVID-19 infection in pregnancy, the severe ones.
Okay. Yep. Since there is emerging COVID-19 cases, so we have to be careful on that. So I think the one of the COVID-19 vaccine is mRNA vaccine, which is actually not really tested in pregnancy at that time, and therefore it's a bit delayed when they try to roll out for the pregnant women, because we know that we have live attenuated, I mean, there are many other type of vaccine that you told us just now, but the mRNA vaccine is a bit new. It's relatively new at that time, so it's
Yeah.
very reluctant for Malaysia and actually worldwide to introduce it to the pregnant women. Okay. Prof YK here has actually asked, how expensive is the flu vaccination and what it is the uptake like for our pregnant women?
Yesterday I just asked the National Pharmacy. So for our influenza vaccine, they charge about 48 ringgit per vial. And then for the Tdap vaccine, now we have the Adacel, so not the Boostrate. Boostrate was a bit expensive. For Adacel, it's about 98 ringgit. So I think in PPM also the uptake is quite low still because it depends on how our staff counsel the patient, and if the patients are willing to pay, so they can get from National Pharmacy and then we inject. But then I think the uptake is not very good still.
Okay. I think Prof YK and everyone here, I think if you are in the UK, they actually routinely give the flu vaccine for all pregnant women. And I think that's a good strategy. And I hope that it actually been also included in the vaccination. So, and also Nadia, you said that our, not the current minister, is our previous Minister of Health
Monday.
has actually tried to introduce it in 2024, but it is in KKM Premier
Yeah, the clinic
Primer,
kesihatan.
sorry, Primer Clinic. So it's clinic
Mm.
kesihatan. So how about UMMC? So what have the department has done? Just update them.
So far, we cannot get the free dose of Tdap vaccine yet. So most of our patients, we join care with clinic kesihatan, so we can follow them up for any pregnancy issues and if they want to deliver here. But then for the vaccine, I think we can ask them to go to clinic kesihatan to get it for the time being.
Okay. So the department has actually forwarded to the drug and therapeutic so that we can roll out this also for the patients. So, but of course, we normally has a joint care with the Kementerian Kesihatan, so they can actually receive that in 2034. But we hope that we can get it approved before the 2034, so that every pregnant woman can get that. I think there is no more question, Nadia. So I think that's all for today for our department. So we have to move on to the next session. So over to you, Prof.
Thank you.